Bismillah ar-Rahman ar-Rahim. Our subject today is orofacial pain. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Acute pain, we have either acute pain or chronic pain. Acute pain results from an injury would generally initiate a reflex withdrawal, that ensuring a minimal or no tissue damage. We have two terms. The first one is an allodynia, which means the injured region becomes sensitive to even light touch, while hyperalgesia, which means an overreactive to painful stimuli. Acute orofacial pain is primarily associated with teeth and their supporting structure, most frequently dental pain, which is due to dental caries, although a broken filling or tooth abrasion may also cause dental sensitivity. Other oral pain are usually periodontal or gingival in origin. Chronic pain. The term chronic pain syndrome has been used to describe a condition that may have started because of an organic cause, but is now compounded by psychological and social problems. It has sometimes been used to suggest a pain disorder that is psychological. Clinically, chronic orofacial pain may be subdivided into three main symptomatic classes. Number 1, musculoskeletal. Number 2, neurovascular. Number 3, neuropathic. Musculoskeletal entities are dealt with temporomandibular joint disorders. Possible causes of orofacial pain or differential diagnosis of orofacial pain. Number 1 is dental pain, temporomandibular joint disorders, neuropathic pain like neuralgias, pathology in related structures, salivary gland and sinuses, eyes, cervical spine and nasopharynx, vascular disorder like headaches, intracranial lesions, neoplasm and multiple sclerosis, referred pain like angina pectoris, and psychological facial pain. The neurovascular pain include trigeminal autonomic cephalgia and migraines, while the neuropathic pain include trigeminal neuralgia, glossopharyngeal neuralgia, facial post-herpetic neuropathy, burning mouth syndrome, painful post-traumatic neuropathies, and central post-stroke pain. Trigeminal autonomic cephalgia are primary headaches with a common clinical phenotype consisting of trigeminal pain and autonomic signs, and these include cluster headache, paroxysmal hemicrania, short-lasting unilateral neuralgiform headache attacks with conjunctival injection and tearing, SUNCT, short-lasting unilateral neuralgiform headache attacks with cranial autonomic features, SUNA, and hemicrania continua. Cluster headache is a severe pain and major autonomic activation. The precise genetic of cluster headaches are unclear, but is likely to involve an autosomal dominant gene. First degree relatives of cluster headache patients are up to 14 to 48 times, and second degree relatives is 2 to 8 times more likely to have cluster headache than in the general population. Cluster headache typically appear in the age between 20 to 29 years and seen in male more than female. Cluster headache is either episodic or chronic cluster headache. An episodic cluster headache commonly occurs at least once daily for a period of weeks at the same time of a day or night, and followed by a temporary remission that may last from weeks to years, and usually occurs around spring and autumn. While in chronic cluster headache, it is a repeated attacks recur over more than a year without remission, or with remission periods lasting less than 1 month. The features of cluster headache pain: it is usually periorbital or ocular. In upper cluster headache, the forehead, temporal and parietal regions are involved, whereas in lower cluster headache, the temporal and suboccipital regions are affected, with radiation to the teeth, jaw, neck, and cheeks. The pain is unilateral and in 20% of cases may change size. The severity of pain of a cluster headache pain is rated as 8 to 10 on a visual analog scale. The quality of pain is non-specific. The pain is either throbbing, boiling, burning, or stabbing. Also, some patients with a cluster headache report nocturnal attacks that wake them. Also, patients suffer from obstructive sleep apnea. Alcohol is a common precipitating factor of cluster headache attacks. Cluster headache prodromes include autonomic signs, which include blurred vision, sensitivity to smell, nausea, dyspepsia, hunger, irritability, tiredness, tenseness, and mild pain or non-painful sensation in the area that subsequently become painful. Migrainous features are common in cluster headache and may confuse diagnosis. Photophobia, phonophobia, nausea, and vomiting are reported in up to half of cases. It is important to note that phono and photophobia are unilateral, while in migraine are bilateral. Differential diagnosis and secondary cluster headache. Cluster headache is often misdiagnosed as dental or maxillary sinus pathology, possibly due to referral patterns and occurrence of lower cluster headache. Secondary attacks اللي هي trigeminal autonomic cephalgia due to pathology have no typical presentation. Neuroimaging must be performed for all tax patients and to atypical tax-like syndromes. The treatment of cluster headache based on attack patterns. Patients should avoid daytime naps, alcohol, and other triggers. Pharmacological treatments may be abortive, transitional prophylactic, and preventive or prophylactic. Number 1, abortive symptomatic relief may be rapidly attained with oxygen inhalation, subcutaneous sumatriptan, which is a neuroactive alkaloid. Number 2, rapid transitional prophylaxis may be attained with corticosteroids that may be continued only for a limited period in selected patients, and this is in both episodic and chronic cluster headache. Number 3, prophylaxis, which is usually with verapamil and topiramate, which is anticonvulsant, as a second-line therapy. Paroxysmal hemicrania. It is a rare with an estimated prevalence of 2 to 20 per 100,000. The mean age of onset is usually 34 to 41 years, but children aged 6 and adults of age more than 81 years have been also reported. The features of paroxysmal hemicrania. It is a unilateral severe orbital or periorbital pain. Majority of attacks do not change sites, but strong pain may cross the midline and very rarely becomes bilateral. It may occur in temporal, periauricular, maxillary, and rarely occipital areas. Referral to the shoulder, neck, and arm is quite common. Patients usually report 8 to 30 attacks per 24 hours that last 2 to 30 minutes. but may last nearly an hour. Pain onset is rapid and mostly peaks in less than 5 minutes. The quality of pain is mostly sharp, but may also be throbbing, stabbing, or boring. The autonomic signs that's associated with this pain, usually conjunctival injection and lacrimation, nasal congestion, rhinorrhea, eyelid edema, forehead and facial sweating, miosis and ptosis. Autonomic sign may occur bilaterally but more pronounced on the symptomatic side. Secondary paroxysmal hemicrania. Systemic diseases, malignancy, central nervous system diseases, and benign tumors have mimicked paroxysmal hemicrania, and therefore all cases require imaging. Treatment of paroxysmal hemicrania. Most cases respond to indomethacin within 24 hours. Indomethacin should be initiated for 3 days at 75 mg, followed if needed by 150 mg for a further 3 days. The prognosis of paroxysmal hemicrania is good and long-term remission has been reported. Short-lasting unilateral neuralgiform headache attacks with conjunctival injection and tearing. SUNCT. SUNCT syndrome is a unilateral headache facial pain characterized by brief paroxysmal attacks accompanied by ipsilateral local autonomic signs, usually conjunctival injection and lacrimation. The similarities of this syndrome to trigeminal neuralgia are marked, particularly the triggering mechanism, and some believe that SUNCT may be a trigeminal neuralgia variant. Features of SUNCT: a unilateral pain, usually ocular, periocular, but may involve most head areas. Pain spreading across the midline or changing sides is rare. The quality of pain is stabbing or pulsating, but sometimes electric or burning. Pain is moderate to severe and accompanied by ipsilateral conjunctival injection and lacrimation. It is more in male at 50 years of age. Pain in SUNCT may be triggered by light mechanical stimuli in the areas innervated by the trigeminal nerve. Extra-trigeminal triggers, including neck movement, precipitate attacks. Short-lasting unilateral neuralgiform headache attacks with cranial autonomic features, SUNA. Essentially, the accompanying autonomic signs differentiate it from SUNCT. SUNA may be accompanied by either autonomic sign, ipsilateral conjunctival injection, or lacrimation, but not both. Treatment of SUNCT and SUNA. Lamotrigine, which is an anticonvulsant, is the drug of choice and should be initiated at 25 mg per day and then increased slowly. Other anticonvulsant drugs such as carbamazepine, topiramate, and gabapentin. SUNCT may also respond to steroids and to surgical microvascular decompression and percutaneous trigeminal ganglion compression. Hemicrania continua is now a part of the TAC family, and it seems to be often misdiagnosed and mistreated. Features: it is a unilateral headache that has been presented for more than 3 months and is a daily and continuous. Pain is diffuse around the half of the head and face, primarily in the frontal, temporal, and periorbital regions. We have 2 forms of hemicrania continua. Number 1, the remitting form, which is characterized by headache that can last for some days, followed by a pain-free period lasting from 2 to 15 days, following a mean duration of 7.8 years. 1/3 of the remitting cases transform to the second, which is the continuous form. In continuous form, nocturnal attacks are reported in up to half of the patients. The most common signs are photophobia, nausea, conjunctival injection, phonophobia, and tearing. A cloudy sensation in the eye has been reported. Hemicrania continua with aura, further linking to migraine pathophysiology. More rarely, nasal stiffness or rhinorrhea, vomiting or ptosis may also be reported. Treatment. The drug of choice in treatment is 75 mg of indomethacin.